So what do we have here? The frontal chest radiograph of a skeletally mature female. Now, what jumps out right away is the diffuse bilateral lung disease. And by diffuse, I mean it involves pretty much all zones. There's this extensive interstitial shadowing, but interestingly, we see relative sparing of the costophrenic angles, both of which remain nice and sharp. That's definitely something to note. Lung volumes are preserved, so no signs of major volume loss or hyperinflation here, and the absence of pneumothorax is clear, no free air visible. Both HeLa are bulky and irregular in appearance, though, and that's a big deal. We don't see any visible calcification there, but there's definitely some irregularity that we'll come back to in a second. Now, as we move down to assess the mediastinum, there's no convincing widening of the right paratracheal stripe, so we can cross that off our list of potential red flags. The heart size is normal, no signs of cardiomegaly to complicate things further. So based on this plain film alone, we've got a case of interstitial lung disease with hilar prominence, but without any obvious consolidation, cavitation, or pleural effusion. Interesting, right? Let's not forget to cross-check the accompanying CT. On the axial CT, we see multiple tiny nodules, particularly concentrated around the fissures. That nodularity of the fissures is a classic hallmark, isn't it? And there's clear mediastinal lymphadenopathy. Those enlarged nodes are scattered, making it harder to ignore the possibility of an underlying granulomatous process. So let's summarize. In a case like this, where we have bilateral hilar enlargement along with interstitial lung changes and mediastinal lymphadenopathy, one diagnosis that rises to the top is sarcoidosis. Sarcoidosis is a multisystem granulomatous disorder, and the findings here, particularly the nodular pattern of interstitial disease, really support that. It's common in young women like our patient here, and the Garland triad, which involves the bilateral hilar, ortopulmonary, and right paratracheal lymphadenopathy, is another classic feature. Now, as for differential diagnoses, we've got a few to consider. Infectious causes, like tuberculosis or viral infections, could present similarly, but would more likely show unilateral hilar enlargement, right? Then there's lymphoma, which could give us bilateral hilar prominence, but typically it would come with more nodal calcification or other signs like more marked lymphadenopathy. Silicosis and treated lymphoma with eggshell calcifications would also be on the list, though we haven't seen any nodal calcifications here to support those. To wrap it up, I'd advise respiratory referral, particularly with high-resolution CT scanning of the chest to further assess the lung parenchyma and lymph nodes. Sarcoidosis remains the leading diagnosis, but we would want to exclude other causes of granulomatous disease. And, just to anticipate what the FRCR examiners might throw at us, they could ask how we would differentiate between sarcoidosis and tuberculosis on imaging alone. And the key would be in the distribution and features of the lymphadenopathy. Another question might be about the management of sarcoidosis and whether we'd recommend biopsy, which typically isn't needed unless we have atypical findings or diagnostic uncertainty. Steroids, of course, are the mainstay of treatment, particularly for progressive disease. That's a wrap on this case. If you're enjoying these breakdowns, make sure to subscribe to the channel for more radiology cases explained step by step. Don't forget to comment if you've got any questions or if you want me to cover specific cases. Thanks for watching, and I'll catch you in the next one.